Hello everyone, I am Dr. Abraham from A&E Dermatology Specialists, Uganda, and today we are going to take a quick look at erythroderma. And this is one of the dermatological emergencies. Every time you see a patient and you make this diagnosis, you need to treat them with the due respect and with the due urgency that they require, because if you don't, you can actually end up losing some of these patients. So erythroderma is a description we give to any skin condition that gives rise to a rash that covers more than 90, some literature say more than 80% of the body surface area, no matter the cause. So either the cause can be an underlying known dermatological condition, skin malignancy, or some cases a cause that's not yet identified, the cases that we call idiopathic. So today we shall look at erythroderma, and we know how to tackle it and the most common causes. So it has been given other different names. In some literature, you find it being called exfoliative dermatitis, or sometimes called exfoliative erythroderma, or sometimes they can also be called the red man syndrome. All these refer to the same description, and actually it's not a diagnosis, but rather a description of a clinical manifestation of skin disease. So when you look at the major key features that we look at in erythroderma, we have it being defined as erythema or scaling covering more than 80% of the body surface area, but some literature can tell you 90%, more or less the same. And then someone will have systemic effects, which you can include things like peripheral edema, tachycardia, or fluid or protein loss, and then also issues with thermal regulation, since they're having most of their skin being involved, and you know that skin plays a key role in thermal regulation. We have the common causes being things like psoriasis, especially in adult patients, drug reactions, atopic dermatitis, especially in younger patients, and then other things like cutaneous T-cell lymphoma, especially the common one, mycosis fungoides, and also the Sézary syndrome. So in the diagnosis, in most of the cases, you require a very good detailed history, and then you have to assess the initial site of involvement that can give you a clue. So if someone had a rash that started in the flexures, then you may think about maybe this is atopy. But if someone had a rash that maybe had been existing for long, a little bit itchy, thin plaques, you may think about things like mycosis fungoides. And some cases you can actually fail to get the cause, and this is what we call the idiopathic. And that contributes up to 30% of the cases. You may fail to identify what is triggering the erythroderma. And in all cases, the treatment focuses on the underlying skin condition. If it's psoriasis, you treat the psoriasis. If it is atopic dermatitis, you address that. And then also, you have to address the complications, including protein loss, fluid loss that come with erythroderma. So when you look at erythroderma, as we've mentioned, that is the body surface area that is covered. And it is not a single disease entity, but rather a description of various skin manifestation of the different skin conditions that can actually present in a very severe way, covering almost the entire surface of the body. We've said that commonly the causes can be either dermatological, where you have things like psoriasis, atopic dermatitis, drug reaction, or even cancers. And it poses a diagnostic challenge, especially if you are trying to identify the underlying cause for patients that you are seeing for the very first time, because almost all the causes, when they now result into erythroderma, the clinical picture is the same. So most of the times you end up writing erythroderma query cause, because it may be a little bit hard for you to identify. But sometimes you can have clues. For example, if I may give you an example, if it is erythroderma secondary to psoriasis, you can look out for other changes on the body that can be indicative of psoriasis, including things like nail changes, the pitting, the transverse lines, the subungual hyperkeratosis. And if it is maybe a tumor like Sézary syndrome, you can now be guided by, maybe if you do a CBC, then you see lymphocytosis, abnormal lymphocytes on a smear. So you can have things like that giving you clues on the possible cause. And then if it's like a drug reaction, you may find that the patient was well before the onset, and maybe there's a history of a particular drug that can be implicated. Then systemic complications can be a little bit severe, because you're involving majority of the skin. You can get things like hypothermia, fluid and electrolyte imbalances, tachycardia, cardiac failure. and other chronic issues like cachexia, alopecia, nail dystrophy, as well as ectropion, where you have now inversion of the eyelids, and that can cause ulceration on the conjunctiva and the sclera, so you end up with actually sequelae that can even result into blindness. So when you are looking at erythroderma in historical perspective, you find that this term originated, or it was first described by Hebra in the 1868, and for that case, he called it exfoliative dermatitis, which was covering more than 90% of the skin. In the classification, it was initially divided into three types, and this was based on the clinical course. So initially, there were just three subdivisions in erythroderma, and the first one, they used to call it a chronically relapsing erythroderma, and that was described by Brock, and then also chronically persistent erythroderma by Hebra, and then the self-limiting epidemic erythroderma. So in this case, someone gets an acute onset of erythroderma, which is maybe if it's a drug reaction, the drug is taken away, and someone becomes better in a few weeks, and it never occurs again. So that is self-limiting epidemic erythroderma. And then the chronically persistent, you find that even with the treatment, the skin continuously has erythroderma or involvement, and that one can be seen in things like psoriasis or chronically relapsing, like in atopic dermatitis, because it has that chronic relapsing cause. And then the modern definition now broadly just categorizes it depending on the body surface area that is involved, above 80%, and that is erythroderma, without actually restricting what is the cause or how is the cause of the progression. So when you look at the epidemiology, how common is this? The precise data is not well available, and this is mainly because most of the reports give actually a retrospective picture, and in that case, you cannot actually estimate the prevalence, so it becomes hard. When you go to the demographics, most of the cases in terms of gender, more men are affected, with a male to female ratio of being ranging between 2 to 1 to 4 to 1, so meaning more males are affected, and the average age group of onset is around 52 years. That is when if you're considering children out, but if you include children, it goes a little bit down around 48. And if you remove children, it will be about 60 years if you don't count children. That will be the commonest age of onset. So the common causes, as we mentioned earlier, dermatitis, that is any inflammation like atopic dermatitis, things like allergic contact dermatitis, all those that classified as dermatitis contribute up to 24%. Then psoriasis comes in next with a 20%, drug reactions at 19%, and then the skin cancer, cutaneous T-cell lymphoma at 8%. But of these cases for dermatitis, most of them are usually due to atopic dermatitis. Then the rare causes can be things like pityriasis rubra pilaris. We have a video on pityriasis rubra pilaris, you can watch it. Other things like ichthyosis, bullous dermatosis, graft versus host disease, even scabies in immunocompromised can become erythrodermic. Then autoimmune or connective tissue diseases can also give you erythroderma, things like SLE, dermatomyositis, and the rest, scleroderma. Then idiopathic causes or cases contribute up to 25%. Some literature says up to 35%. And in that case, you would not be able to identify the cause of the erythroderma. So when you go to pediatric causes, majority of these can be due to inherited ichthyosis or even dermatitis or even psoriasis, plus other immunodeficient diseases, as well as infections. Infections like staphylococcal infections can give you the staphylococcal scalded skin syndrome, the SSSS, and that one can also give you erythroderma. Plus, other drug reactions like the chain, the SJS, also contribute to these causes. So in the pathogenesis, the exact mechanism actually remains unclear, but more often times it is thought to be influenced by the underlying medical condition. So if it is atopy, if it's atopic dermatitis, the pathogenesis, it follows the one of atopy, where you have environment playing in, the genetic predisposition, where you have immune dysregulation, epidermal barrier dysfunction, and then microbiome destabilization. So in this case, we have an increased keratinocyte activity with increased gene number and mitotic rates. That means that keratinocytes are dividing a little bit faster, and they are transiting through the epidermis at a very, very fast rate. That's why you're having a lot of shading, a lot of scaling with the erythroderma. So this scale is very significant and increases the daily skin shading from the normal, which is usually 0.1 to 1 gram per day per person, to around 20 to 30 grams per day. So this increases the burden of protein that someone is losing. So remember, whatever skin you're losing, that is part of your body protein. So if you're losing 20 to 30 grams of proteins per day, so that means that you're losing a lot of protein, and that one can also lead you into other complications, the hypoalbuminemia in blood, the reduced oncotic pressures in blood. At the end of it all, you're having generalized anasaka or edema and the rest. Then in acute causes or in acute cases, you can have a minimal metabolic impact because it comes for a short time, especially for drugs, and then after that it goes. But if it persists for long, like the chronically persistent, according to the previous description by Hebra and the friends, you'll find that you end up having a good impact on your protein levels, especially the albumin. So someone can end up with hypoalbuminemia, as well as other things like anemia and electrolyte and fluid imbalances. So we have also immune factor contribution. In this case, we have age-related immune senescence likely contributing to the idiopathic erythroderma in older patients. And also in children, there's also immune deficiency, which shouldn't be overlooked as one of the things that play a role in immune dysregulation underlying erythroderma. So when we go to the clinical picture or how erythroderma will present, as we've said, someone will have erythema and scaling covering more than 80% of their body surface area. It can either be classified as primary or secondary. So primary, usually it has a rapid onset of erythema, oftentimes starting on the trunk. Then this will go ahead to spread and cover the entire skin, and then eventually it will be followed by scaling. Then when you go to the secondary type, in this case, someone has generalization of a prior localized skin disease. For example, you have a chronic plaque psoriasis, maybe located on a few areas of your body, maybe the sacral area, the knees and the elbows. Then all of a sudden, then you get the generalization of psoriasis that becomes now erythrodermic. So that is usually what we call secondary. So in primary, initially the skin is normal, nothing is there. Then all of a sudden you get this erythema, then desquamation, then following in a very short period of time. So that is primary erythroderma. Then in secondary, comes initially when you have a pre-existing skin condition that is usually localized, can be atopy, psoriasis, or MF, or the rest. Then scaling varies depending on the stage and the underlying condition. So if it is acute, sometimes you can get large scales with crusting. And then if it is chronic, the scales tend to be a little bit smaller and drier and fine. And this distinctive pattern can also give you an idea. Fine scales are seen in atopic. If it is a seborrheic dermatitis, you can see brand-like scales, and if it is a drug reaction, you just see exfoliative scales. So because in drug reactions like chain and SJS, you have maybe epidermolysis, you have sloughing of the epidermis, so you get exfoliative kind of picture. So when we go to the other cutaneous manifestations, sometimes it can present with pruritus depending on the cause. So if it is atrophy or things like Sézary syndrome, mycosis fungoides, pruritus may be present up actually 100% of them if those are the causes. Then we can have other things like dyspigmentation. Oftentimes can either be hyperpigmentation or hypopigmentation, which follows the desquamation. And then you can end up other things like erythroderma, where you get plantar erythroderma in about 30% of the cases. And this can be, it can vary depending on the underlying cause. So if the underlying cause is this ichthyosis, you can also have palmoplantar keratoderma. You can also get nail changes up to 40% of the cases. This can include things like shininess. The nails will become a little bit shiny, because as someone is rubbing, they usually polish the nails and the nails will look shiny. Others get brittle nails. Others also get total nail loss, because the condition can also affect the nail beds in some cases, depending on the cause. And others can also end up with alopecia. Most of the time, it is the non-scarring type. And we can also get cicatricial alopecia in things like the Sézary syndrome or even epidermic mycosis fungoides. In that case, when the hair loss happens, it never comes back. It just remains with a scar on the scalp. So that's what we call the superficial alopecia. So additional complication, we have things like seborrheic keratosis, staphylococcus colonization, or even secondary infection, ectropion, conjunctivitis. We can also have it exacerbated with UV light exposure or even drug ingestion. So you can be managing erythroderma, maybe secondary psoriasis, but then you give a drug that gives you 10. So that can actually complicate the picture, and then someone can end up actually being like a burns patient, losing almost all the skin. So in this picture, I'm trying to show you the different stages, how it will look like. First, you usually get erythema, that background redness on the skin. Then you end up now getting the scaling that comes after. Then this is now the desquamation that comes after. So in this other picture, in this tiny picture, I wanted to show you how Psoriasis subacterialis usually appears. In some cases, it is also erythrodermic. And remember, we have a video on this, but just a reminder, we know that in PRP, we usually get the keratotic papules on a background of erythema that usually gives you islands of sparing, or where we have areas of normal skin. And this is what you are seeing in this picture. So these are areas of normal skin, the ones that you see looking like whitish. So that's the normal color, but then the rest is erythema with these keratotic papules. So that is Psoriasis subra pilaris, and in this case, it's the generalized type, which is the typical type, and that is the adult form, that is type 1, Psoriasis rubra pilaris. So if you want details on this video of Psoriasis rubra pilaris, we've made one video there. You can actually go and watch it. Then when you go to the systemic manifestation of erythroderma, we see that some of the patients, up 50%, they actually end up with edema, which can either be the pedoedema or tibioedema, facial edema seen in cutaneous T-cell lymphoma, or even drug-induced cases. They can also get cardiac or fluid balance issues. In this case, they can get a tachycardia. You have lost the oncotic pressure, so you lose the blood volume. So your heart tries to beat faster to compensate for that loss. So that's the tachycardia. That's how it will come in. And then this fluid imbalance, as I told you earlier, someone is losing about 20 to 30 grams of protein per day. So they end up with hypoalbuminemia. And you know that albumin is the key oncotic pressure protein that we have in our plasma. So if you lose that protein, it simply means that you have lost the oncotic pressure. So meaning that your blood cannot hold a lot of plasma. So you now extravasation of fluids, especially water, from the intravascular spaces into the interstitial spaces. So that means that your total volume of blood goes down. So as an attempt, what your heart will do to compensate, it will beat faster, and that will give you the tachycardia. And then the hypovolemia can actually complicate and then give you things like kidney injury first. If the kidney is now damaged, now the liver gets damaged, and then the heart gets damaged, and the blood and the brain and the rest follow through. Then we have issues with thermoregulation, because you know that our skin barrier is very key in regulating temperature, and the vasculature in the skin is very key as a thermoregulator. We know that when your core body temperature is high, we usually get vasodilatation on the skin to allow you to lose excess heat. But when the temperature is low, that means that you get vasoconstriction in the skin, such that the core body temperature is maintained. But now, in cases where you're having erythroderma, you have increased transepidermal water loss, you have increased transepidermal heat loss via radiation, convection, and conduction to the environment, because you have disrupted the skin barrier. So you can end up with issues of either hypothermia, because patients they will feel these chills and hypothermia, because you're losing a lot of heat. And then you can also get metabolic issues, because now as you're losing this heat, your body tries now to break down the the stored fats to generate more heat. So you can actually end up stimulating a lot of metabolism to go on to give you the excess heat. So because of this, you now lose a lot of your body weight, your body mass, and that is what we call cachexia. You lose weight, and because your body is trying to compensate. So someone with erythroderma actually can lose. Maybe someone will tell you that I was actually 80 kilograms before I got this, but when I measured, I'm now 70. That is actually possible. You can lose up to 10 kgs in one day, or even more. And then you have other things like anemia, which can be mixed type. Most times you can get iron deficiency anemia, or you can also get anemia of chronic disease, which is usually a microcytic type of anemia. And then you can get lymphadenopathy in about 50% of the cases. And most times you can, if there's an underlying infectious cause, your body will try to now form the white blood cells, and that process occurs in the lymph nodes, and that's when they will give you those palpable lymph nodes that we usually see in 50% of the cases. So some of them end up with hepatomegaly, as the liver is required to undergo proliferation or to enlarge in order to meet the body needs. And then other complications like splenomegaly can occur, and as well as other colonization or infection with staph aureus. So when you look at the picture, if you have to take off a biopsy, now biopsy will be very key in erythroderma. Why? One, no matter the cause of erythroderma, the clinical picture can be the same. So in order for you to distinguish or to have a clue on what is actually going on in this case, you may need to take off a biopsy. So in this case, when you take over a biopsy, the biopsy can give you sometimes good results or some other time vague results, which are not actually conclusive. So depending on the pathologist that is reviewing your samples, you may get different or differing results. For example, in this case, the first picture that is A, it is showing you that in this case, it's actually the typical psoriasis that was causing the erythroderma, because you're able to see this monor abscess, you're able to see this regular kyphosis, and then you are also able to see the parakeratosis, and that is maybe a little bit clear. Now, in type 2, or in the second picture here that you are seeing, we are seeing a little bit of more spongiosis, and then also parakeratosis with almost loss of the typical basket wave pattern. So you have it being replaced by this parakeratosis, and I told you parakeratosis simply means retained nuclei in the stratum corneum. So that's what we are having, meaning that the cell layers are being overturned at a very fast rate, and this doesn't allow for maturation of the cells as they move from the basal layer to reach the corneal layer. So that is now due to atopic dermatitis. Now, in this case, you're having an interface type of reaction, and this is due to a drug reaction. And then in this case, we are having these lymphocytes, which will now be a clue pointing to malignancy like mycosis fungoides, but in this case, it was Sézary syndrome. As you can see, these lymphocytes forming nests just below the what? Below the DEJ, the dermal junction, and you see the little bit atypical, and this is Sézary syndrome. So depending on the cause of the erythroderma, the biopsy can guide in some cases. But some cases you can actually take off a biopsy and it is not conclusive, just showing this spongiosis, and that's it. So you treat the erythroderma and then wait to see if you get any typical primary lesion that can now give you a clue. So when you go to the specific findings for the different underlying causes, if it's psoriasis being the common cause in adults, it can be actually triggered because of withdrawal of either steroids or methotrexate or an infection or even other irritants. So in this case, you get the classic psoriasis features when you take off a sample. And then even when you examine the patient, you can get things like the nail changes, where we usually see the oil spots or the salmon patch, the subungual parakeratosis or debris. Then you have the ragged cuticle. So you will get psoriasis from nail changes. Then if it is atopic dermatitis, oftentimes you'll see someone who have very intense pruritus, as you see in atopy, 100% of the cases have a pruritus. So you'll have like anification and then excoriation. And then when you do serum IgE, it will actually be raised with eosinophilia, which may accompany the condition. If it is drug, you can get a wide range of systemic involvement, or even topical drugs can induce erythroderma. And in this case, you will see your erythroderma resolving within 2 to 3 weeks after you have discontinued the medication. But in some cases, they can persist, and they can actually present like a pseudo-Sézary syndrome, which can actually complicate or confuse the picture. So all these things are supposed to be on your mind as you're managing a patient with erythroderma. So if it is idiopathic erythroderma, that represents up to 25 to 35% of the cases, oftentimes in elderly men, and if you present with chronic pruritic erythroderma, may be associated with dermatopathic lymphoadenopathy, or also called the red man syndrome. And in that case, they can also get palmoplantar keratoderma. So the red man syndrome, they just called red because of the erythema that comes with the erythroderma, and it is generalized, and it usually moves with involvement of the palms and so. So they get a palmoplantar keratoderma of a sort, as well as a lymph node enlargement. And then if it is due to actinious T-cell lymphoma, that usually includes the Sézary syndrome and then the erythrodermic mycosis fungoides. And in this case, if it is Sézary syndrome, you have a triad of erythroderma, Sézary cells, and then also a lymphadenopathy. So oftentimes, if you have a patient with erythroderma, then you palpate the have palpable lymph nodes, you may need to actually look for now the Sézary cells in blood and see, as well as in the skin biopsy, to see if you have those cells. So in that case, oftentimes it is very painful. They will have a painful keratoderma, alopecia, as well as severe pruritus. Then if it is pityriasis rubra pityris, that one I've shown you even a picture. You will see the salmon red lesions with follicular papules and then with islands of sparing, as you've seen in the picture. So if it is papilloerythroderma of Fuji, in this case, you'll have a pruritus, a red-brown papules with a deck chair sign, or it spares usually, the skin folds. So when, for example, if you're sitting and your bum folds, so when you spread it out, those areas that are folded, they're not involved. So that is the deck chair sign that we guys see in the papilloerythroderma of Fuji. So when you go to the paraneoplastic and associated erythroderma, so if it is the paraneoplastic erythroderma, so oftentimes you get, it can occur with lymphoproliferative disorders like the lymphomas. Also occasionally, has also been reported in other cancers like the thymomas. And in this case, malignancies are typically absent in the skin, but they may be present in late presentation if someone has a solid cancers, and then erythema may have a brownish melanoerythrodermic hue, oftentimes with the signs of other things of these symptoms like the weight loss, fatigue, night sweats, that can make you think that maybe someone has an underlying malignancy. So we can also have erythroderma occurring because of an underlying blast condition, like you can get erythroderma secondary to pemphigus foliaceus, secondary to paraneoplastic pemphigus, or even in blast pemphigoid. So this one, usually someone will tell you they have blistering or vesicles, and in that case can also give you a clue. So you get a scale where a scale like priced that usually overlies a denuded area. So when you try to remove the crust, you usually see a denuded area, and that's how the blister will usually leaves the skin looking. So that one may be a little bit easier to think about the blast condition, because someone will tell you in the history that usually have this blistering. But then when they say that, you have to also think about other things like a same amount from which can have a blast variant, and you can also think about other blast or blistering drug conditions like drug-induced blast pemphigoid, or drug-induced pemphigus foliaceus, or even a drug-induced blistering conditions. Then for if it is ichthyosis, you'll have now a history that was present maybe from infancy, or things like congenital ichthyosiform erythroderma or Netherton syndrome. These ones are usually diagnosed even from the history and from the clinical picture that the patient maybe was the history that you get in the neonatal period, that period after birth. How was the skin looking like? Were they born in a collodion membrane or no? So if there's such a history, then you can think about ichthyosis as being one of the causes of the erythroderma. So if it is Staphylococcus cowded skin syndrome, the SSS, now you usually see this one in children, so you can think about it in adults, commonly in those below the age of 5, and it is caused by the exfoliative toxin of Staph aureus, and symptoms may include erythema, tenderness, and discrimination with usually a high-grade fever. And then Omenn syndrome, which is a genetic immune deficiency presenting in units. Oftentimes, it also has signs of erythroderma, alopecia, hepatosplenomegaly, and then also severe infections if you don't do a stem cell transplant, usually these children end up dying. So this one may be diagnosed a bit early, so it will be key when you're dealing with in pediatric population to think about Omenn syndrome as one of the causes of erythroderma in that particular age group. So this table tries to summarize what do you actually do if you get a patient of erythroderma. First, you have to take a very good clinical history and physical examination to see at least if you can identify any primary lesion of the patient. Is there blistering condition features, or do you have nail involvement? Do you have oral involvement and mucous membranes? Do you have hair involvement? Do you have alopecia? Do you have lichenification? Do you have plaques with scaly with silvery scale? So what do you have as a primary reason? Try as much as possible to identify it. For example, if you have maybe a few lichenoid papules with violaceous background, maybe when you do dermoscopy on them, then you see Camus-Troyer. So you can tell this is the erythrogenic lichen planus. So if you have things that are suggestive of psoriasis, nail changes, then you can say maybe this is possibly psoriasiform or Erythroderma, and there is. Then you have to take a full history and with evidence of pre-existing inflammatory condition. So if someone has maybe there was a history of a rash before the Erythroderma, then you take details of that rash and it can guide you on the underlying condition. So in that case, if there's a history, you have to search for the primary lesion. This can be confirmed with histology. Then you manage the primary condition, and then the patient will be okay. If there's the history of exposure to medication, you have to discontinue the medicine. And then you can also, if you see improvement within 2 to 6 weeks, then you can maybe think it can be maybe either drugs, another drug reaction with the exception of drugs, because we know drugs can usually persist even after 2 to 6 weeks. Then you can think this is maybe a drug-induced cause, and then when you remove the drug, the patient will be okay. But if there's no history of any drug, no history of any clinical illness, you can think that maybe this may be any other idiopathic erythroderma. You can guide and take off, examine your skin, take off a biopsy, and then you do the laboratory investigation, including the flow cytometry. So in that case, if it is rare, you can get other things like the hypereosinophilic syndrome, giving you erythroderma, paraneoplastic syndrome, it can either be a lymphoma or a solid organ tumor, or you can also have it being cutaneous T-cell lymphoma, where you either have Sézary syndrome or erythema or erythrogenic mycosis fungoides. So this table tries to show you the common causes of erythroderma as well. So when it comes to treatment, in the general treatment, actually, these patients have to be hospitalized or admitted. Then you have to do nutrition assessment. Then you correct their food and electrolyte imbalances. You protect them from hypothermia and secondary infections. Then you can also do oral sedating antihistamine to relieve the pruritus that comes with some of these causes of erythroderma, as well as at least make the patient comfortable. Then you can do systemic corticosteroids. Either you can do prednisolone at 1 to 2 milligrams per kilogram body weight per day. Also, in some cases, you can even do the methyl prednisolone, and that one calculate the pseudo dose depending on the patient's weight. So you can also do topical therapies where you give like things like emollients or potent corticosteroids to try and alleviate the inflammation. You can also do high potency corticosteroids for areas that are lichenified, or we can also do but in this case, you have to avoid the colta as well as acetic acid or lactic acid, especially in children, because you are now having damage to the skin barrier. So you can have cyclic acid being absorbed into the skin, then giving you side effects. So for specific treatments like in psoriasis, we usually prefer methotrexate or acetretin or even cyclosporin as the drug of choice, or even a biologic if it is available. And then you can, if it is drug-induced, you usually stop the drug and then give systemic corticosteroids. Then if it is idiopathic, you usually give systemic corticosteroids as we monitor and see. But in case it refuses, you have to give a cyclosporin or any other immunosuppressive agent like methotrexate, azathioprine, or even mycophenolate mofetil. So I thank you very much for watching this video. I encourage you to subscribe and share with your friends. See you in the next video. God bless you.